Good afternoon, everybody, or late good morning for some of you. The title of today's webinar is Protecting Child Passengers Now and into the Future. It is sponsored by the Children's Safety Network. My name is Rich Hamburg. I'm the Executive Director of Safe States Alliance, and we're an active member of the CSN Alliance. This project is supported by the Health Resources and Services Administration, HRSA, part of HHS, under the Child and Adolescent Injury and Violence Prevention Resource Centers Cooperative Agreement. Information or content and conclusions are those of the author, not be construed as the official position of policy, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. Before I introduce our two speakers, my colleague Rebecca Wilmer has a few technical announcements. Rebecca?
All right. Thanks, Richard. So audio is currently being broadcast through your computer speakers. The quality of the audio depends on the speed of your internet connection. So if the audio is choppy, you can either try and find a more stable internet connection, or you can listen over the phone by dialing 866-835-7973. If you are listening through the phone, you can mute your computer speakers, and that will eliminate any echo. Phone lines will be muted during the presentation to eliminate any background noise. Answers to frequently asked questions are in the webinar instructions pod that you'll find on the upper left. And if you have any questions or technical issues, you can type them into the Q&A box on the bottom left at any time. After the presentation, we'll pause for the presenters to answer your questions. We also have a PDF of the slides available to download right above the slide deck. To download it, you can click on PDF of slides and then select the Download Files button to save the document to your computer. And this webinar will be recorded, and the archive will be sent out to all registrants within 2 weeks. All right, back to you.
Thanks, Rebecca. So let me start off with some introductions of our two speakers today. Dr. Joyce Pressley is an Associate Professor of Epidemiology and Health Policy and Management at Columbia University Medical Center. She works with Columbia's Injury Control Research Center, ICRC, where she serves as Principal Investigator of the Motor Vehicle Research Grant, co-directs Center Outreach and Education, teaches injury and violence prevention, and serves as the faculty lead for Columbia's Injury and Violence Prevention Certificate in the MPH program. Her experience in research, teaching, and injury prevention is multidisciplinary, crossing the boundaries of public health policy, epidemiology, emergency medicine, critical care, economics, and healthcare management. Her recent and upcoming publications include evaluating the impact that laws and policies exert on motor vehicle occupant injury, as well as the economic burden, particularly for front and rear-seated motor vehicle occupants, risk factors for poor crash outcomes, including side crashes, and the contribution of comorbid disease risk to poor injury outcomes. On the national front, she's been active leadership of several national injury prevention organizations, including serving as chair of the Injury Control and Emergency Health Services section of APHA, chair of the Council of Centers for the Society for the Advancement of Violence and Injury Research, SAVER, and director of Health Policy and Population Health for the Injury-Free Coalition for Kids. Dr. Pressley holds a PhD degree from Duke University. Looking forward to playing Duke Michigan State fan here. Next, Aditya Belwadi. Dr. Belwadi is a research scientist for biomechanics and autonomous vehicle research at the Center for Injury Research and Prevention at Children's Hospital of Philadelphia, CHOP. 2011, he received his PhD in biomedical engineering and began his research career at CHOP. As a postdoctoral fellow at the center from 2011 to 13, he was instrumental in developing advanced finite element computational modeling capabilities at the center. And as of 2015, he also leads the Center's Child Passenger Safety Research Team and is a certified child passenger safety technician. Dr. Belwadi is an internationally recognized expert on injury biomechanics, injury causation, and the effectiveness of safety products for children, and his research efforts have been funded by the National Safety Foundation, NHTSA, and several corporate entities in the field of automotive safety. Dr. Belwadi has presented both nationally and internationally, been recognized by the Society of Automotive Engineers, SAE, for his work, received the prestigious Ralph H. Isbrandt Automotive Innovation Engineering Award in 2012 from SAE for his work on lumbar spine mechanics. So let me turn it over to Dr. Pressley to begin the presentations.
Thank you, Rich. So today we're going to be talking about protecting child passengers now and into the future. While significant progress has been achieved in child occupant safety over the last few decades, there are long-standing unsolved challenges, newly evolving threats, and exciting emerging technologies in the road ahead of us. In addition to the conversations being conducted around what child safety in the autonomous vehicle should look like, there are continuing issues that need to receive simultaneous attention if we are to achieve the highest level of safety for our infant and child passengers in a rapidly changing transportation environment. All 50 states, D.C., and U.S. territories have laws requiring children to be restrained while riding in motor vehicles. However, there's variability in the ages covered across states. There's uneven enforcement, a range of penalties for failure to properly seat and restrain. Many are secondary laws which require drivers to commit another offense before they can be ticketed for the improper transport of an infant or a child. There's a growth in the use of vehicles for hire to transport children. The importance of this is that in most states, almost all, taxis and vehicles for hire are exempt from infant and child restraint laws. Currently, gaps in our surveillance systems do not capture whether a vehicle is operating in for hire mode or as a private vehicle. Currently, NHTSA's conducted surveys document child restraint use as hovering around 90%. Booster seat use in the ages recommended for booster seats, 4 to 7-year-olds, hovers around 40%. Nearly one-third of deaths in this age group are unrestrained. Further improvements appear to have stagnated. Car seats have been reported to reduce the risk of fatal injury, 71% in infants and 54% in toddlers. Restraint use is much lower in older children. The CDC's Whiskers interactive database shows large disparities in infant and child motor vehicle passenger mortality. These large historical race and ethnic disparities are maintained or in some cases widening. Infant and child occupant mortality is 2 to 3 times higher in non-metro areas. And there's a large proportion of motor vehicle traffic deaths in these age groups that are unspecified, making it difficult to assess the full burden of occupant injury. There are shifting trends in where parents and child caregivers obtain their information. We have a need to strengthen our use of social media. Not all sources being consulted are equally accurate and up to date. We need further research on the impact of effectiveness of our message content. There's currently a failure of impaired drivers to transport children properly restrained and rear-seated. We're in the midst of a prevalent opioid epidemic. There's rapidly growing trend toward legalization of non-medical use marijuana, gaps in drug and alcohol testing across states, and increased risk associated with polysubstance impairment. There's a great need to improve ease of child seat installation, to standardize vehicle and seat compatibility. The logistics of color coding is being discussed seriously right now. We had a meeting in January, and we'll have another in July to continue talking about this. There's a need to harmonize terminology and to decrease seat misuse. In regard to advances in vehicles with various levels of autonomy, there is initial higher predicted uptake is in vehicles for hire where large gaps in restraint laws exist. It may exert an impact on driver impairment and proper restraint of children. There's exciting biomechanical work underway on the safety impact of seating configurations and biomechanics of crash testing. Dr. Belwadi is going to speak to that in a few moments. We're going to now quickly glance at how some of these issues impact infant and child morbidity and mortality. First, we're going to examine state-level variations in child occupant restraint use, mortality, and the strength of state occupant restraint laws. We examined about 20,000 pediatric occupants aged 0 to 12 years who were involved in a fatal collision in the 5 years between 2010 and 2014. 15% died. On the next two slides, you can see variation in child restraint law by state and by primary and secondary law coverage. This slide shows percent of unrestrained occupants involved in a fatal collision over this 5 years. Infants and children covered by primary law are shown in blue here and the secondary law in yellow. You can see how annual motor vehicle restraint use rates varied across states. If you look at the yellow on the top of the bars here, you can see that half of the top 10 states with the highest non-restraint use rate have some child ages that are covered by secondary law. This here, you can see the same format of slide showing annual motor vehicle occupant mortality. Again, rates per 100,000 vary across states, ranging from 0.3 in Rhode Island to 4.6 per 100,000 in Wyoming. Again, more than half of the 10 states with the highest child motor vehicle rates had gaps in pediatric restraint laws. 2 states that are below the median for mortality had more than half of their child mortality in children that were not covered by their restraint law. This shows the same states we saw in the previous 2 slides. As dots, you can here see the inverse relationship between percent restrained and mortality rate for ages 0 to 12. Percent restrained is shown on the x-axis and the mortality rate on the y-axis. As percent restrained goes up, mortality rate goes down. Here you see roughly parallel lines for both primary and secondary law states exhibiting a decrease in mortality with increasing restraint use, but with the secondary law states remaining relatively higher than the primary states. This is a figure, and the next one is from our published work in the Journal of Pediatrics on the epidemiology of driver, drug, and alcohol screening, restraint use, and mortality in fatal crashes involving a child passenger. Nearly 29% of the 11,000 drivers involved in a fatal collision while transporting a child were tested for both alcohol and drugs. More than half, 57%, were tested for neither alcohol or drugs. Child passengers were less likely to be properly transported by a driver who tested positive, but this varied significantly, as you can see here, by the age of the child and by the, also by the drug and alcohol category. In multivariable adjusted odds ratios of child passengers being unrestrained, it was 25% higher if the driver was positive for drugs, 70% higher if the driver was positive for alcohol only, but 2.4 times higher with polysubstance use, drivers who were positive for alcohol plus another drug. Of interest is nearly 28% of the children driven by drivers positive for cannabis were unrestrained. This slide shows percent mortality of child passengers aged 0 to 12 years involved in fatal crashes by age group, with 0 to 12 on the left and 13 to 14 on the right. You see that the front seating position carries higher mortality in both age groups. Shown on the graph on the left, the mortality is generally threefold higher in unrestrained children or occupants aged 0 to 12, but it actually approaches fourfold in ages 13 to 14. This slide demonstrates disparities in restraint use across the age span for crashes on Indian lands compared to the states that house those Indian lands. These findings are robust across vehicle types. Restraint use in teens aged 14 and over is just over half on Indian lands compared to non-Indian lands. This disparity is exacerbated when you look at impaired status or alcohol and drugs. While total restraint status was almost double on non-Indian lands, when examined by alcohol and drug status. This disparity in teens shows non-Indian lands are about 3 times more likely to have restrained teens than Indian lands. As few as 12 to 20% of teens who were in crashes on Indian lands and who were being driven by somebody positive for drugs or alcohol were restrained at the time of crash. This is from a study that's currently in press that shows unrestrained infants have about 3-fold mortality compared to restrained infants. We've started to communicate our message, and we're sort of testing this out for infant and child restraint lifespan in terms of stages. Stage 1 with rear-facing infant seats for as long as the child sits. Stage 2, forward-facing child restraints. Stage 3 with booster seats for proper belt positioning. And Stage 4 for seat belts. We're starting to communicate that to mothers who are still in the hospital with the caveat that you're now in Stage 1 so that we don't dilute the message that's important for them with their infants. This slide shows improved but low adherence to recommendations for infants age 0 to 2 to be rear-facing, while infants age 0 to 1 involved in a fatal collision improved over the time span of the study and were more likely to be rear-facing than 1 to 2-year-olds. Total documented rear-facing adherence remained at less than 25%. There's much room for improvement here in law enforcement documentation and for driver adherence to rear-facing guidelines. The next few slides demonstrate why exclusions to infant and child restraint use should be reconsidered. These exclusions are nearly universal across vehicles for hire and taxis. This study is a New York State Health Department Academic Center collaboration. It's also currently in press. So, although the value of child and teen restraint riding in a motor vehicle is well established, there are huge gaps in terms of kids who are being transported in vehicles for hire. These vehicles for hire are on the rise in terms of their use. In New York, persons age 16 and over are also exempt from restraint use in private vehicles. So this study is examining seatbelt use in private vehicles for person compared to taxis in New York City. We use the crash outcomes evaluation system. This was uses a probabilistic methodology to link emergency department data, hospital admissions, trauma registry data, and police reports. This is looking at restraint use in 0 to 19-year-olds for rear-seated passengers. You see that private vehicles are pretty similar to the national average we saw with the NHTSA surveys, hovering just under 90%. Taxis is lower at 51%. For taxis, although 50% under age 8 were unrestrained, fewer than 6% were restrained in an infant or a child booster seat. So this slide shows the strongest predictors of restraint use for pediatric passengers were driver belt status and being transported in a private vehicle. Other significant predictors included older driver age, female driver, younger passenger age, outward seating position, the crash occurring in one of the 4 counties outside of Manhattan. The speed limits are higher out there. Daytime crash and fewer than 4 passengers in the vehicle. Unbelted passengers, age 0 to 7, were more likely to be injured. Oops, I have a blank on my screen. We appear, okay, sorry about that. So this slide is showing the percent of crashes with traumatic brain injury by belt status for private passenger vehicles and taxis. Traveling in a taxi was associated with higher TBI, whether belted or unbelted. However, being unbelted in either a taxi or a private vehicle was associated with a doubling of the percent of passengers who sustained TBI. Nearly 4% of unrestrained taxi passengers involved in a crash experienced TBI. The higher TBI status in belted passengers may be due to the underuse of appropriate child restraints or potentially to taxi design differences where there are credit card charge machines, plexiglass dividers, and TVs in there. In summary, there are several important current challenges to pediatric occupant safety. Unless successfully addressed, these are likely to be carried forward and continue to be issues as vehicle automation advances. There are trends in race and ethnic, socioeconomic, and non-metro disparities in pediatric motor vehicle injury. Special geographic jurisdictions such as the Indian lands we saw have low restraint use in placing the pediatric populations at increased risk. Primary laws are associated with higher restraint use. States with secondary laws have lower restraint use and also higher mortality. We're seeing changing drug laws, particularly legalization of non-medical cannabis, where we see lower proper seating and restraint use in pediatric populations that's being driven by drug and alcohol and polysubstance positive drivers. Alcohol and drug use in drivers of pediatric passengers is associated with increased child endangerment, front seating, and lower restraint use. There are scientific obstacles to roadside testing and a lack of standards for what under the influence constitutes. There are newly evolved involving drugs aimed at escaping screening detection, with many drugs that need to be tested not having a roadside technology. There's not a clear dose-response relationship between a positive test in driving impairment in drugs such as cannabis. As we have noted before, taxis and vehicles for hire are generally exempt from rear seatbelt laws. Multi-purpose vehicles that cross over from use as a private vehicle for hire, Ubers, Lyft, ride-hailing services are on the rise. Current data systems based on vehicle registrations do not accurately capture when a vehicle was in for hire mode or in private use. Driver training and licensing is required for known vehicles for hire, but frequently not for the crossover vehicles. Challenges in equipment terminology, harmonization, seat vehicle compatibility, ease of use, and behavioral responses continue to be issues. Solutions are currently being discussed as part of the continuing moving the needle advancing pediatric passenger safety. There will be a July 2019 meeting in December where we will examine some of these issues that we started examining at our meeting in January. In January, we brought together representatives from lead organizations and vehicle manufacturers, car seat component manufacturers, vehicles for hire, and academics in D.C. around a single table using the format of the TRB annual meeting pre-conference human factors workshop. We examined current and emerging issues in child occupant safety. Dr. Belwadi was with us at that and gave a fantastic talk. I'm looking forward to hearing him again in just a moment. We looked at the issues that we've just talked about here. We also looked at the possibility of message expansion and what that might mean to parents, many of whom think that once they get their child out of the car car seat, that they are finished with their job. Some parents will even say, phew, I'm glad that's behind me. But we're seeing this post-car seat group, the booster seat, and the preteens and early teenagers starting to emerge as a high-risk group. So we've discussed the pros and cons of early adoption of the 4 stages of passenger safety that I noted earlier, with the idea that possibly beginning education in the hospital room with new mothers to briefly list the 4 stages with a statement, birth to 15, you're at stage 1 of 4. We'll discuss this in a continuing and ongoing conversation with key people around the table at our meeting in July. So if you want to join us, please get in touch with me. My contact information is here. I wanted to acknowledge my colleagues who have worked on some of the work that we just presented. Michael Bauer, Leah Hines, and Matt Garnett from the New York State Department of Health. Maria Vega, who's been great with this, is now retired from NHTSA as the Occupant Protection Division. Laura Dunn, her successor, has been quite helpful. Cindy and Rebecca helped us with webinar support, and we had nice support from the Transportation Research Board. We also want to thank the attendees and organizers of the TRB workshop, Moving the Needle, Advancing Infant and Occupant Safety. Please be in touch if you want to become further involved in this. Dr. Belwadi?
All right. Good afternoon, everybody, and thank you for joining, or good morning based on where you're calling from. Can we move to the slide? One second while I switch over. All right. First of all, Joyce, thank you so much. Your presentation was fantastic as always, and this nicely set up my talk, kind of trying to understand some of the modalities of injury going back into the biomechanics of pediatric occupants. So the way I've set up today's talk is I'll kind of take you back a few years, then bring you back to the present, and then take you into the future as to what really is happening next. So most of this data was mined around early January, so all the statistics and numbers are very current. So for those of you who don't know who we are part of the Center for Injury Research and Prevention at the Children's Hospital of Philadelphia's Research Institute. We have several areas of research, including child road traffic safety, young driver safety, that's getting into teen driving and driving simulators. We also have a very strong injury prevention and bullying program. And I represent the engineering and the child passenger safety team here. So our sort of objective is very simple and straightforward. We are dedicated to advancing safety of children, youth, and young adults through research, through impact, through action. So we have truly come a long way with everybody's efforts, everybody who's joined us today and beyond. I see some familiar names here. You've all played your part in truly making child passenger safety a priority and helping reducing and saving lives. But the simple story is not enough anymore. We really have to dig through and understand how can we sort of customize, get into what we call as precision prevention, and sort of lay out next steps so we still reduce that number, bring it closer to zero. So just looking at some data from the World Bank and global burden of safety, we know where motor vehicle safety stands today. It's still the #1 cause of injury and fatality for kids from 5 to 30 years of age, and in the top 5 between birth and about 5 years of age. That's very significant. And that number has gone down over the last 3 decades. We have substantially seen reduction in fatalities for kids under 13 years and under 12 years of age, close to about 45% in the last 10 years. And that's primarily been due to several factors: increased restraint usage, highway safety laws, advanced restraint systems built into the vehicles, and more importantly, the vehicle crashworthiness itself, just the layout of the buttons or the steering wheel, the stiffness characteristics, and how the seating position plays a huge role in injury mitigation. So what we saw a year before is some of these numbers were slowly ticking back up. We saw that some of the fatalities, especially for kids under 6 years of age, was slowly increasing. This was a gradual increase, and several factors were attributed to that. Economy doing better, more vehicles on streets, same infrastructure, so that causes an increased density of vehicles, going next to each other. So there's a higher propensity of crashes. When you normalize that data, we see that in general, the fatality distribution has sort of decreased. So if you look at 1981 through, say, 2010 and 2016, we see that motor vehicle crashes and the fatalities have decreased, but the distribution, so if you compare the green plot versus the red, motor vehicle crash distribution is about 36% in 1980s, and today it's about 31 to 33%. So the distribution still remains the same. So pediatric motor vehicle safety and injury prevention is still a significant problem. So how did this all start? So going back to the early 40s and 50s, Colonel John Paul Stapp, who was a physician in the U.S. Navy Corps, said that we needed a surrogate or a device or a crash dummy to better understand this. So at this time, we didn't really have crash test dummies. So he decided to strap himself on a rocket sled and went from about 600 miles per hour to zero in about 1.4 seconds. We can play the video here.
Ribs. He damaged almost every part of his body in these runs, and he made these runs over and over and over again, knowing what was going to happen.
Well, his sled run, and by the way, I was the chase pilot. I was flying an aircraft when he made that sled run back in 1955. I actually flew the airplane right alongside of him, and that was one of the most phenomenal events that I've ever witnessed. Here a man went almost 614 miles an hour. He knew exactly what physiologically was going to happen. He knew he was going to get a horrible beating, a life-threatening beating. But he knew that this research needed to be done, and he established the actual limit to deceleration.
Very severe injuries. This is one of the first documented physical crash tests of a living human volunteer, and that was the last ever after that. Thank goodness. So right after this, that's when crash test dummies became very predominant and very public. I mean, there were several companies and manufacturers and vehicle manufacturers developing crash test dummies over a period of time. But what we realized from this test, and which is still significant today, is although Dr. Stapp went from 600 to zero in 1.4 seconds, he did not sustain a fatality. It got manufacturers thinking that in an average motor vehicle collision, you go from about 30, 40 miles per hour to zero, and there is usually a fatality or very severe injury. How was this different from what you see in traditional impacts? One of the biggest differentiating factors, and it's quite obvious, is there is no intrusion. There is no compartmental intrusion. The side door structures or the steering wheel or the buttons are not flying towards your face. So right after this is when the field of injury biomechanics started becoming very popular, is trying to understand what is the relationship between acceleration or deceleration versus displacement or intrusion. And for those of you who are Formula One racing fans, you would appreciate that racing cars and racing structures have a lot more systems and enclosures going around. So you have roll cages, systems, customized seats, helmets that are attached to the shoulders, and so on. So the field of biomechanics sort of originated from Dr. Stapp's sort of initial testing. And since then, we've seen a plethora of restraint systems, whether it's the introduction of seat belts to some of these early restraint systems. I'm sure several of you have actually seen, used, and hopefully don't see it today, but we do occasionally see some of these in storage. But what's interesting is how the field has actually, step by step taken a stance to a point where, and these are sort of de facto standards, whether it's the early 40s and the 50s, and then moving on to the first safety belts introduced by Volvo in the early 60s, and then the ATDs or the crash test dummies, or more popularly called anthropomorphic test devices. Anthropomorphic means human-like. And then the Department of Transportation and NHTSA establishing testing guidelines, coming up with both cadaver and crash test dummies. and instituting regulations, which has really made a huge difference in reducing reducing fatality and improving the quality of life, both before, during, and after. So with that in mind, let's try to understand what are the injury mechanisms in a typical car crash. So we're all very familiar that when a car crash happens, the first collision is the crash dynamics. This is your vehicle impacting an object or a tree or another car or so on. The second collision that follows is occupant kinematics. This is essentially occupant that impacts the vehicle structure, and this could also mean the seat belt or an airbag. And the third collision is what we call as impact biomechanics, and this is internal organ motion. So if you visualize your brain moving around in the cerebrospinal fluid inside your head, it's kind of essentially sort of bouncing around in there. So during an impact, it moves forward and backwards, sort of a rocking motion, and contacts your skull. So there is a pressure gradient which is formed, what we call as a coup and a contra coup sort of injury. And those are internal organ motions. For the first crash, which is the crash dynamics, it's sort of very straightforward. We have restraint systems, we have advanced collision systems today. We have what are called as ADAS systems, getting into lane, departure warning, or giving you the blind spot notification and so on. So these are pre-crash systems which protect you and prevent you from the crash itself. The second collision that happens can also be sort of trimmed a little bit based on airbags and seat belts and deceleration profiles. It's the third collision that causes all the problem, is how do you protect or how do you prevent your skull or your heart or your lungs from moving internally within the body? And that's the tricky portion, and that's where impact biomechanics research comes into play. You can play this video if you... Great. Here's a quick example of a typical crash mechanics. We're all familiar with crash dynamics and first collision principles. If you want to go back. Great. And what we do is we sort of combine that with reconstruction mechanics. We look at post-collision analysis, getting into accident reconstruction, and then bringing that back into occupant mechanics. Then we look at crash test dummies. Here's an example of what we call as ATDs, or anthropomorphic test devices. And here's an example of a crash test dummy in a booster seat, getting into pre and post collision and how some of those belt components really help us understand. Joyce had a slide earlier looking at belted versus unbelted occupants. And this is a great example of simple restraint system mechanics. Is when you have an unrestrained occupant, what we see is occupants essentially flying all over the occupant compartment in compartmental space. I don't know if the video is playing here, but I can't see anything on my screen. Oh, there you go. Great. Here's a quick example of what really happens during a belted versus unbelted scenario. Right. Move back. And skip back to the slide. Great. Thank you. Okay. Before I get there. So the third collision is essentially the injury biomechanics piece. And what we do in our labs here is we essentially try to understand how can we quantify some of these motions, some of the organ motion using computer models. We generate pediatric human body models. We are one of the first organizations to come up with a 6-year-old human body model. This is in conjunction with the EU consortium, which is a very detailed human body model with internal organs. And one of the really cool things that we can do is sort of do what is called as a virtual autopsy. You can literally dig through inside the model. And here is an example video of what is an aortic injury. So the aorta is the main blood vessel which supplies blood to the rest of the body, or the rest of the organs. And a crash reconstruction is a classic example as to how we can post-analyze some of these forces, some of the injury mechanics, some of the momentum, and come up with proper restraint conditions, whether it's an airbag, whether it's a seat belt, whether it's fine-tuning some of those nuances, and understanding and mitigating injury. So how does this translate from adults to children and then to kids actually sitting in cars? Kids are very flexible. I have a 3-year-old and she does all these fancy poses. I cannot. And as the human body develops and grows, the bones calcify, material properties change, ligament laxity changes, physiological outcomes changes as well. So there's quite a lot of, look, feel, move, predict injury kind of thing happening. And kids don't sit like crash test dummies. One of the big challenges is we don't really want to be getting into PMHs or cadavers or any of those tests. We're also not doing animal studies, thank goodness. Human volunteer tests. Colonel Stapp did it a while ago, and one of the fun things at work that we do is we went up to Six Flags in New York, sat in one of these bumper cars, and instrumented a bumper car with, accelerometers and gauges, and came back and built a mini bumper car setup in our lab. It's a very controlled, low speed, low acceleration setup, but what it really helps us do is it helps us understand how kids actually move in a low speed impact. Albeit it's a low speed impact, we have 3D markers and 3D marker setups that really help us understand how young occupants and young child move in a very simple bumper car. We then take this data, scale it up, and insert it back into a human body model, scale that human body model back up to, say, 30, 40, or 50 miles per hour, and run it to a setup where we really understand how the body or how a pediatric occupant actually behaves and how they move in a typical crash setup. So we can switch back to the slide. Great, thank you. So here's a quick comparison of a typical 6-year-old head-top motion versus a 30-year-old. You can see the stiffness characteristics play out, and that changes how a traditional occupant versus a pediatric occupant move in a similar crash setup. So what we've concluded is kids are definitely behaving differently. They're not scaled down adults. We often hear this, that material properties have been scaled and so on. Kids and pediatric occupants are much different. They're not scaled down adults, and that's an important distinction to make, and use that research to change for safer roads. And so I'll kind of take you to the next side of the story, is kind of getting into a little more prevention, precision prevention, and what does the future hold for us in the next couple of years. So you can play this video, please. Thank you. So this is a crash test video from the Insurance Institute of Highway Safety. Some of you might have seen this video, but essentially what it is the one on the left, or in this case we start with the right, is a 1959 Chevy Bel Air, and the one on the left is a 2009 Chevy Malibu. And it's a very interesting video here because this is what is called as a typical frontal offset. So it's not completely head-on, it's slightly offset by 50% offset. There's an overlap, and what you see is very interesting. If you look at the Bel Air, the crash dynamics, the crush profile is just shattering. The windshield is all over the place, and there's a great, this is the view I was talking about. You can actually see what is happening inside the vehicle. The dummy's head is over the roof, the steering wheel is right in the dummy's head and the dummy's face, and buttons and things flying around. But now let's take a look at the Bel Air. The Malibu. And you can actually see the airbag being deployed. Looks very plush and neat. Airbag plays a huge role. Restraint system. So the primary restraint system here is your seatbelt and airbag. And as you can see, there's nothing flying out there. So crash dynamics, stiffness characteristics play a huge role in mitigating injury. It's the collision 1 and collision 2, which helps us bring down collision number 3. So we can switch. Go back to the slide, please. Thank you. Okay, so what's next? Several of you have heard of highly automated vehicles, self-driving vehicles, autonomous vehicles. They are not something that's going to happen in the future. They are happening. Several manufacturers, pretty much every single manufacturer out there has some investment in, incentive in here, And the incentive is very simple. The incentive is to reduce fatality. We still see about 35,000 fatalities every single year on American roads. The only way we could sort of bring that number down is to get the human out of the picture. Time and again, from our research, from research centers across the world have shown distraction, not paying attention to things, or simple tasks like taking over, or talking to people, or your cell phone falling off the passenger seat are classic examples of distraction. And the human plays a huge role in almost all of these systems. So for us, it's a very unique opportunity to do child passenger safety from ground up. Joyce spoke about ride sharing, ride hailing, mobility as a service model, or transportation as a service model where you're actually renting on a regular basis, or even using Uber and Lyft are great examples on how some of these systems can change. Volpe, funded by NHTSA and DOT, looked at the federal motor vehicle safety standards that are currently written and came up with a very detailed report. I have a snippet here on screen which says that the seats are arranged in a conventional manner, but occupants can spin those seats around. So essentially what you have is what are called as non-standard seating position. A standard seating position is where you're looking out, looking into the front. A non-standard brings about a very unique set of questions, whether it's economics in terms of swiveling, space, motion, how do you recline, what do you do, or ergonomics, how do you get in, what is the comfort level, or more interestingly, some engineering questions about safety, airbag placement, and more importantly, where do kids and adults sit? So we at the center, we have a center within a center called CCHIP, so the Center for Child Injury Prevention Studies, which is an industry-funded university collaboration with the National Science Foundation, have kicked off a series of research. This is a body of research that my colleagues Helen, Polly, and myself are looking at. So the first one on the left talks about what are called as reaction times. These are takeover times in case an autopilot fails, in case there's an emergency. How quickly can you take over the steering wheel? The second is what we're looking at is understanding how do you interact with occupants? How do you interact with other occupants, whether it's pediatric occupants or young kids or young children in a non-standard seating position? So just imagine for a second, in a typical car, you're looking out, you're looking in the front, but if you have to sit in a vehicle wherein you're looking at the other passenger for 20 minutes, it becomes uncomfortable after a while. It's like a restaurant-style seating position. But more importantly, what happens in a crash? What are the biomechanics associated with it? And if you don't mind playing this video, here's an example of a simulator-based scenario, which is a highway-based scenario looking at two-way occupants or two-way vehicles coming at each other. If you don't mind playing this video. I don't see the video playing here.
It is playing.
Oh, it's playing. Okay, I don't see it here. So this is essentially a takeover scenario where the driver or the autopilot fails and starts veering onto the other lane. And it's a controlled environment. We had participants from teens, young drivers, adolescents, and our oldest participant was 99 years of age. And actually, she was one of the best across the board. So it talks about reaction times. It talks about distraction and trying to understand how quickly can you jump in and take over a steering wheel or a situation like that. The second is a body of work that I'm looking at understanding non-standard seating position. We've developed a reconfigurable seating buck. Essentially, all of these seats are part of a vehicle, a mock-up vehicle in a lab, and these seats can rotate or swivel around. And in the far right, you can actually see a 5-year-old, 4.5, in a forward-facing convertible seat, and his seat is actually swiveled and rotated, and the driver on the far left is actually facing forward. So this is a static evaluation that is in a lab-based setup. So trying to understand how do occupants interact? What are the questions? What are there particular seating positions that work? Some don't. Simple things like leg room. You want to stretch your legs. If you have a particular seating configuration, that may work, may not work for extended period of time. The other question that we are asking ourselves is how do these work in the event of a crash? a dynamic setup wherein you have a crash and what really happens in some of these. So these are called as non-standard seating positions. And what we're doing is we're running human body models. Each of the model that you see here on screen is a computer model, a human body model. So there are organs, tissues, ligaments, and so on. And we have a child placed in there. This is an initial example of trying to understand with seats, with child seats and without child seats, but gives you more of an understanding of the interaction. We want to see if an adult sitting right opposite, right next to each other, would their legs interact with each other? What are the extremity interactions? And then go on a step further to understand where do airbags need to be placed? What happens if you're turned around and get into a crash? What are sort of the deployment characteristics and so on? Go to the next slide, please. Great. So with that in mind, kind of want to start wrapping up. One of the criticalities of all of this is we need each other to make a difference. We need all of you, working on child passenger safety, conveying the right messages to parents, because as we kind of lay this out and develop, we are working with manufacturers to understand nuances. And we all have a fantastic opportunity here to do child passenger safety in a unique way, go down to the bottom and really work our way up in looking at non-standard seating positions. It's not in a dystopian future, it's happening. We are working with manufacturers right now on some of these situations, and so we need all your support and partnership. Do stay current with our research, our publications. You can subscribe to our research and action blog at injury.research.chap.edu, or also look at cchips.research.chap.edu for projects, publications, and reports. I want to extend a huge round of thanks to our entire SERP CHOP team and our collaborators at The Ohio State University, Rowan University, and the Penn School of Medicine. And without our funders, we would not be here. I want to, again, extend acknowledgments to all our funders, vehicle manufacturers, child seat manufacturers, NHTSA, FAA, Transportation Research Center, and some of the work that Safe Kids have done with us over the years. With that, I'll pass it back to Rebecca and Cindy. Thank you.
So this is Rick. Thanks to both of you. Great presentations on recent research and historical perspectives. That was terrific. We do have about 7 minutes left. I want to run through a couple of quick questions. First off, Dr. Pressley, one participant asked if you could explain what you meant by color coding of car seats.
So currently, there is confusion about where latches and anchors are located and how the seat is to be installed, how the vehicle manufacturers are making those attachments to the vehicle available. So we have an association of automobile manufacturers, and the seat manufacturer of the largest number of components for a number of car seat producers and retailers who are at the table and discussing whether or not and what kinds of things need to be done to put a color code on the vehicle strap and anchors, as well as on the seat, so that you could, say, put yellow to yellow and green to green. We are in the process of discussing some potential obstacles in terms of when seats turn around and go forward-facing versus rear-facing. So this is not a done deal yet, but it's certainly doable for a certain age group. So we're still working on this. We'll continue this discussion between now and July, and then again around the table in July in D.C.
Thank you. Appreciate that. Also a reminder that you can type questions into the box at the bottom left of the screen, although I do have a number of questions have been submitted. One for Dr. Belwadi. Terrific set of videos there. Are any or all of them available via a particular link or multiple links? Thank you for your interest. Most of those videos are available online on our website, but I'd be happy to share them if there's any interest. I can send it out to Cindy and Rebecca for distribution if there's any interest. Terrific. Yeah. Thanks. Appreciate it. One question was, how do we best support new parents in understanding the laws and the changes in laws and child and information around child development related to that? Either you want to address that?
I think there are a number of injury prevention groups that are operating in hospitals, especially hospitals where they have birthing units and trauma centers of either 1 or 2 level, where they are required to do injury prevention programming and research, so that those groups, those hospitals have more resources, and those mothers have more resources than who might get at some of the smaller hospitals. Safe Kids actually runs the child passenger safety technician training programs. We are looking at ways to communicate more effectively with parents. We've got a grant in, it hasn't been funded yet, that would allow us to sort of have a central repository for a child injury prevention or general injury prevention sort of library that parents could go to. In the meantime, there's NHTSA has a website, Safe Kids has a website, several hospitals have individual websites, but a lot of parents are getting their information from other parents and from people on Facebook that they are friends with, and from other social media sites, or from just the general internet. So we have an active discussion going on about how to address that. I hope that's helpful.
Yes, that actually helped answer a couple of questions. A couple of quick additional ones. Any good multilingual websites in Spanish or other languages for parents to learn more about car safety, or either the sites you mentioned or any other ones? And then part 2 of that, is there a particular website that does the best job in letting parents know which are the safest child seats?
I think NHTSA does an excellent job of rating car seats. IIHS also does some car seat ratings. That both of those are very good. Safe Kids does and is at the table discussing how we communicate with parents and how we should change our messaging and our modes of messaging so that we are reaching all parents and not just those that are that are giving birth in high resource hospitals.
One other website that I would recommend is healthychildren.org. This particular website is sort of run by the American Academy of Pediatrics. It is also giving parents information. You can subscribe to their blog posts and online forums. There's also information and child passenger safety related knowledge on Spanish. And further, it also gives you a list of top-rated child seats for different ages across different brands. So that's a great site. It's healthychildren.org. Thank you. We're almost to the end here. My apologies, because there are a lot of good questions that were posed. One quick final one. So this is a good closing one. What is the most important thing injury prevention coordinators and child passenger safety technicians can do right now? Just a quick response to those two, to that question. I mean, I can go first. I would suggest, I think current technicians are doing a fantastic job. I think that we have a wonderful network through Safe Kids, and Safe Kids does a phenomenal job in sort of promoting that information. I would keep that going and just connecting with families and directing them to the right resources. We see a lot of traction when people are directed to the right resources and they are online or getting that information. We've also seen manufacturers take an onus upon themselves with releasing new technology and applications or phone apps for parents now. Most car seats now have QR codes that the parents can scan, and it'll take you right up to the manufacturer's website. So that's another great resource. But I think you guys are doing a fantastic job, and I would, keep that going.
Great. Let me cut it off there. I appreciate the presentations, the great questions, the responses, and I want to thank both of you and the audience again, and ask everyone to complete the quick evaluation of today's session. You'll see the SurveyMonkey link there. And again, appreciate everyone's participation. Have a great rest of the day, and want to stay right on time here. So enjoy the rest of the week.
Thanks, Rich.